Welcome back. I'm Dr. Max Cohen, and we're going to be talking about pharmacology as it pertains to the athletic trainer. These slides are generally all coming from the Principles of Pharmacology for Athletic Trainers textbook from the authors that you see here, sort of the gold standard for pharmacology knowledge for athletic trainers. I am going to try to emphasize and de-emphasize what I think are elements that are going to help us focus a bit better. This is going to be a part one that is going to address the foundations of pharmacology and medications, and then there will be a part two that is going to go into depth about specific treatments and learning a bit about how to think about medications and how to maybe make recommendations for over-the-counter medications. So to start us off with our introduction to pharmacology, there are two important concepts that we're going to start talking about, which are how the drugs affect the body, and then how the body affects the drugs. Now, there's terminology for this that we'll learn in a moment, but one is going to be essentially the therapeutic response, the cellular targets of medications, and the other is more of the idea of how the drug passes through the body in regards to its absorption, distribution, metabolism, and excretion, and we'll learn what all of those terms mean shortly. The first is pharmacokinetics, and I like to think about this as the effect of the body on the drug and the factors that affect that time course of how various drug events occur and when. And then pharmacodynamics, which is the effect of drugs on the body. Again, that's sort of the mechanism of action, cellular targets, effects, toxicity. And overall, we define a drug as a chemical that is intended to prevent or treat a disease process. There are several important names with drugs that can make things a bit confusing. The chemical name is the actual cellular components named by the carbon rings and such, if you think back to organic chemistry. And those don't make an appearance too much in the practical clinical world of athletic training, but the generics and trade names do. And you might already know that the generic name is the name given to a drug that is the non-proprietary name, for example, acetaminophen. Whereas the trade name is the proprietary name given by the company that's marketing the drug, for example, Tylenol. The chemical name, here's an example, very long, I'm not even going to try to pronounce that. And I think, for our purposes, just know that it exists. And then, we're going to work to have some familiarity with some more common generic and trade names for some of the more common medications that you'll come across. And an important note here, not all drugs are marketed as generics. And a lot of companies will make alterations to a drug, how it's delivered, as sort of right before the patent is about to expire, so they can get continuations of those patents that prevent it from becoming generic. And a lot more complexity to that, but suffice it to say that generics are going to typically be less expensive than the trade name product. And if a medication was previously trade name and becomes a generic, it will generally become cheaper, more competition in the market, and it usually does not differ significantly in how patients respond to these medicines, maybe with few exceptions, in which case a physician, when they write the prescription, they'll say dispense as written. Perhaps there's a very specific formulation of an anti-seizure medicine that when the patient is on the brand name, they are well controlled, and then when they're switched to generic, they have issues. Perhaps that's a patient that will just continue on the trade name. There can be several issues with trade names, and one of that is that you have to remember several trade names for that one generic, and it can make it really difficult to communicate amongst different interested individuals. The example here of Vanquish being a product that contains aspirin, acetaminophen, and caffeine, it can be sort of confusing that all of those different generic medications are combined in that trade product. So it can sort of make it harder to talk about these things. Some ways that we classify drugs are based on its structure, mechanism of action, and legal classification. We'll kind of go through these one by one. The chemical structure of a tetracycline, for example, tetra meaning four, and cycline meaning cycle or ring or circle. You can see that doxycycline, which is an antibiotic of the tetracycline family, shares a four-member ring that you can see here in the picture. But more commonly, you will probably be using groups of medications based on the intended action. For example, beta adrenergic agonists are medicines like albuterol that are going to act on the beta adrenergic sympathetic activity to open up the airways and can often increase the heart rate. And Then we might talk about other medications like beta blockers, which are going to act on those same beta receptors to antagonize or inhibit or block them, and typically have an opposite effect where they'll slow heart rate and maybe with different clinical indication, but a similar drug target. The legal classification can sometimes be helpful to talk about for athletic trainers, especially because the over-the-counter medicines and non-prescription are medicines that you're going to probably be coming into contact the most with as far as perhaps making a recommendation for something to take for an athlete who has some sort of complaint. The non-OTC drugs we think of as prescription, and then is sort of a subset of that. We think of controlled substances or scheduled drugs that are prescription and require sort of an additional amount of care to make sure that they are dispensed and handled properly. With the over-the-counter drugs, the patients and athletes that you'll be working with, they do not require a prescription. They tend to have less drug than a prescription medication, meaning an over-the-counter steroid, topical steroid cream might be able to get to 0.1% of hydrocortisone, but you might need a prescription for 2.5%, for example. And these are medications that have been deemed to have generally low frequency of adverse effects, don't need a lot of monitoring of, for example, kidney function or liver function, and that are effective at an appropriate over-the-counter dose. The prescription medications do require medical supervision and, generally speaking, tend to have a greater potential for harm if not carefully prescribed, monitored, discontinued, etc. And certainly can make some interesting observations here about oral contraceptive medications, which have now become over the counter, and thinking about how these medicines differ in safety and efficacy. And then the controlled substances that we were going to talk about, they are ones that tend to have a potential for abuse. And there are 5 schedules based on the accepted medical usage and potential for abuse. The Schedule 1 drugs are thought to have high abuse potential with no accepted medical use in the United States. Certainly this is debatable, but currently at the federal level, marijuana, LSD, and heroin fall into this category. As you're maybe well aware, a lot of moving parts with marijuana and how state policies differ from federal policies, and where research is headed as far as medical indication for marijuana for different pain syndromes, anxiety, sleep, etc. But for our purposes, helpful to know that it is a Schedule 1 substance technically. Schedule 2 have some high abuse potential but have accepted medical use, and that includes things like cocaine, OxyContin, hydrocodone, Ritalin, morphine. You may have heard of people getting morphine for severe pain. Medications like cocaine actually might be used for bleeding control in ENT surgery. OxyContin might be used for pain control after a procedure. Ritalin for ADHD. But these are medicines that, if not appropriately managed, can become abused and potentially used incorrectly. Schedule 3 medications tend to have a bit lower abuse potential, but and still have an accepted medical use. Things like anabolic steroids or T3, you might have heard Tylenol with codeine. The codeine element of that being a lot lower on the abuse potential scale, and that sort of drops it into the Schedule 3 class. Schedule 4 has even lower abuse potential, but accepted medical use. And the 2 main examples here are Valium and Xanax, which are benzodiazepines, medications that may be used for alcohol withdrawal or insomnia or anxiety, and but do still require really close physician oversight. And then you have the Schedule 5, which is considered to have the lowest abuse potential, and these are sort of cough syrups with codeine is probably the best example in this category. I think you get an idea for the pattern. There are several different drug acts that may be helpful to know about. I don't expect any of you to memorize all of these things, but just a general sort of survey here that back in 1906, there was this act here, the Pure Food and Drug Act, that said you can't really misbrand or adulterate the food and drugs that are being promoted. And then in 1938, the Food, Drug, and Cosmetic Act said that you have to test new drugs for safety, and that there was sort of a drug approval process kicking off there. The Durham-Humphrey Amendment was, in addition to that, divided medications into prescription and non-prescription categories, which was a helpful distinction. Then you have the Kefauver-Harris Amendment that then said you need to test for efficacy in addition to safety, and this really formalized a process for drug approval. The Comprehensive Drug Abuse Prevention and Control Act of 1970 added restrictions on prescribing, storing, dispensing medications, all sort of in the name of safety and reducing potential for abuse. And that kind of brings up a good time to discuss the drug approval process. When there's an idea for a drug, you have to have preclinical testing. You're trying to come up with um, a drug target and a indication for that medication. And then there are phase 1 through 3 clinical trials that are required to initiate an FDA approval process. And then after that approval process, there's phase 4 where you're sort of the drug has been approved, it's in circulation, and then you're reviewing data after that point. Again, assessing for efficacy, safety, dosing. The preclinical testing is often done in a laboratory at first, and then potentially on animals, which is of debatable morality, but as of right now, this is how the process is. Which brings you then to the phase 1 trials. This is usually very small numbers of participants who are generally healthy, and it's over the course of a couple years trying to see if the medication is safe at test dosages and to get the pharmacokinetic parameters. Again, how the drug is being absorbed and distributed and excreted in healthy humans. In phase 2 trials, you again have sort of a small number of participants, and these are participants who have been diagnosed with the disease process of interest, or the condition that the drug is intended to treat. And over a couple years, you are assessing the small group to test for safety, but as well as effectiveness now, to get an introductory idea of whether this medication seems to be safe and helping this small group of people. In phase 3, you get a large number of participants who have the condition of interest, and over several years, you're again assessing the effectiveness and safety, evaluating for adverse effects, and then if this is a successful process in applying for FDA review and possible approval. If it's approved, then again, you have your phase 4 where there's the post-marketing monitoring, looking for long-term adverse effects. As you can see from the previous slides, there was not really a 10-year study required to get approval. And so this is where some of that data comes out that might say there's a risk of diabetes with long-term statin use or something to that degree. And then it might also compare with other treatments to see what's better, what's more effective, what's the new gold standard. Drug recalls are processes in which medications are sort of pulled from distribution, and they come in a couple of different classes. The class 1 recalls are when there's a very reasonable possibility of serious threat to the health of the consumer. And that differs from class 2, where there may be a reversible or temporary health problem or the remote possibility of a serious health effect if patients are using that medication. And class 3 is when it's not likely to cause a health hazard, but is still a abnormal process of how the drug was developed, perhaps an issue with the quality, and it's pulled from distribution. As far as drug information and where to sort of go looking for some of this drug-related information, because again, we don't expect you to know all of this off the top of your head. You should feel comfortable with maybe having a couple of resources that work for you. The physician's desk reference is a very reliable option if you like having a physical reference book that you can actually have the physical copy. And for some over-the-counter references, the Handbook of Non-Prescription Drugs may be a good option to have around the athletic training room. There are several textbooks, as the ones mentioned here, but perhaps even more helpful are the electronic references that we have now. Internet sources like Hippocrates, this is a very good resource. And then if, for example, you have a concern about a patient of yours who is breastfeeding and you want to know about the effect of the medication on the baby or on lactation, there's an app called LactMed. There's several resources that you might find for really high quality apps. You just have to go looking for them, but they can be very helpful. And then if you want to see specifically sort of the interaction between the important parts of pharmacology and athletic training, you might go to the International Olympic Committee or the National Collegiate Athletic Association to read a bit more about rules and regulations in that overlapping area. So that brings us to pharmacokinetic principles, which again are the processes that affect the drugs from the entry to the exit. And I will try to hit some of the key elements here without dwelling too much. Feel free to pause and read as needed. But the pharmacokinetics, the processes that are going to impact the dose, the dosing interval, and the route of administration, you could imagine that a medication that has a very long half-life as opposed to a medication that has a very short half-life will require less frequent administration. And that all comes down to pharmacokinetics. The absorption is the first important element, and that's how the drug gets from the pill into the bloodstream. And that might be by mouth, by IV, by rectal or inhalation. And each of those administration methods are going to cause different amounts of drug to get into the bloodstream at different periods of time. Then you have the distribution, which is the movement of the drug throughout the body and moving from areas of high concentration to areas of lower concentration. The metabolism, which is how the drug becomes altered by the body as it passes through the bloodstream and different organs. And then excretion, which is how the body gets rid of the drug, which might be through the urine or the feces. And some key concepts to understand here are the site of action, which is the drug target, where it's going to have its biological effect, and different variables will affect that you can imagine relating to where the receptors are that you're trying to target, what enzymes are associated. This is a graph of the plasma concentration of drug over a period of time. You'll note that the onset of action is the point at which the plasma concentration of the drug reaches the minimum effective concentration. And then from that point, the plasma concentration continues to its peak, and then it slowly comes down over a period of hours. And for this particular drug, the point at which that dips below the minimum effective concentration would determine your duration of action, the time from the onset to the termination of action. And the T1/2 that you see with the black arrows here is describing the half-life, which is the amount of time that it takes for half of the drug to be metabolized. Some key phrases for you. And the bioavailability is the word that we use for the portion of drug that actually reaches the systemic circulation from how it was administered. The two main components are the amount of the drug absorbed and the rate of absorption. After it's absorbed, the drug goes through a process of what's called first-pass metabolism, and you'll have some inactivation of the active drug by the gastrointestinal tract and the liver. And depending on the route of administration and the formulation, you might end up with varying degrees of effect from the first pass metabolism. Bioequivalence is a word that demonstrates that there's two or more similar formulations of the same drug that act very similarly. In this example here, you see varying plasma concentrations of a drug that over time is going to result in different lengths of action. And the distribution, as we mentioned, of available drug being dispersed in the body, the more extensive the distribution, the higher the volume of distribution. And some things that will affect that are whether it is water or fat soluble, whether it's binding to proteins in the bloodstream, how big the patient is, and how those interactions and bonding with the chemicals are taking place. For example, here you have albumin, which is a protein found in the bloodstream, and the D that surrounds that, that's various amounts of the drug that's binding to the protein albumin, as opposed to the D on the bottom that are representing free drug, and that's drug that maybe can pass across the capillary wall, whereas when it's bound to protein, it can't, and so it can't get to the site where it needs to have an action, perhaps. The chemical structure that we talked about is going to affect a lot of this because if it's a very large drug, it won't be able to pass through smaller holes in membranes or receptors. If the shape is appropriately able to bind to different membranes, and then the solubility, again, is going to determine whether it sort of mingles well with water or fat. And that sort of leads you to the concept of solubility, or the properties of the drug that determine where it's going to be most easily able to be absorbed, distributed, and excreted. The more water-soluble drugs are what we call hydrophilic. The more lipid or fat-soluble are what we consider lipophilic or hydrophobic. And when you think about cell membranes, you remember that they are a phospholipid bilayer made of cholesterol and fat, some proteins that may have transport mechanisms. And so you might be able to get medications to passively cross across that membrane, or you might have to use different transport systems in that cell to actively transport it. This is an example of that lipid bilayer, where you have a net movement of these drug particles from the area of higher concentration to the lower concentration across the cell membrane by what's called passive diffusion, whereas active transport requires energy. And this may be more of a competitive process because the molecules are competing for receptor availability. The route of administration is worth talking a little bit more about as far as how the medication is getting into the body and getting to the site of action. The dosage form is the physical form that the drug takes. So, for example, a tablet versus a capsule, or a solution, and all of that will affect the absorption of getting the drug into the bloodstream. The oral route of administration is one of the most common, and it tends to be very convenient for patients, fairly safe. But as it passes through the gastrointestinal tract, there's going to be a bit more inactivation of the drug by the GI tract, and then as it goes through portal circulation, more of a first pass effect, or the liver is going to deactivate some of that drug, and this will also maybe affect the length of time that drug is able to be active. Some examples of tablets and capsules. And then there's liquid dosage forms like syrups and elixirs, suspensions and emulsions. And these are all going to be dissolved in solution and are going to maybe have a faster rate of absorption because of the faster rate of dissolution based on where it's absorbed in the small intestine. Then you have the concept of what can affect oral absorption. You have food and contents in the stomach that are going to delay absorption. And then certain interactions with, for example, heavy metals. If you are trying to take your iron pill and it's competing with another medication or food that with a lot of calcium, for example. And then it's helpful to be aware of the different types of formulations of oral medications that can make the release of the drug take a longer period of time and have a longer or delayed onset and duration. Then you have sublingual and buccal, or meaning in the cheek administration, rectal administration, like a suppository that becomes absorbed through the rectal mucosa, and then parenteral drug administration, which is intravenous or intramuscular predominantly. And this tends to have a more rapid therapeutic response. If patients can't eat or perhaps have a lot of inflammation or swelling in their gut, then they're not going to be able to get a lot of good oral absorption. So this is helpful for those folks. And but then some disadvantages, sort of, obviously in the athletic training setting, we often don't have access to IV route of administration, and there's a lot of safety concerns related to a high level of skill that's needed to safely establish an IV and give IV medications. Intramuscular subcutaneous is also going to have a very rapid absorption, and muscle has really great blood flow, so is a good site for getting medications absorbed. Then you have topical administration, in which you are applying a medication to the skin, and you are, based on the solubility, the surface area, the blood flow, going to get different rates of absorption, and often going to have more of a local effect when desired. For example, a topical steroid may have really high ability to treat eczema at the area where it's applied, but there's fairly little systemic absorption when not applied to the face at least, and this can be really helpful. But then other medications, like perhaps testosterone that's applied on the skin, you might be able to have higher levels of systemic absorption, which you may desire for somebody who's being treated for low testosterone. And these often come in lotions or creams, ointments, and the nicotine patch is the example that they give here for getting a systemic dose of nicotine by a transdermal patch. Then you have inhalation, which is when the drug is inspired via a respiratory tract, and it tends to be very rapidly absorbed due to the excellent blood supply to the lungs, high permeability of the membranes in the lungs that are doing a good job of getting oxygen and carbon dioxide across these membranes. So inhalers are a great example of that, like metered dose inhalers or dry powder inhalers that we use to treat asthma and COPD, and also nebulizers, which similarly nebulize a solution of, for example, albuterol to open up the patient's airways. And then I'm not going to talk too much about distribution here. This is, again, moving the drug throughout the body, dependent on several important variables. We'll talk here really quickly about the blood-brain barrier. There's a tight junction that's a lipophilic barrier at the brain, and that limits access to the central nervous system. So some medications are able to pass the blood-brain barrier, and other medications are not able to pass the blood-brain barrier as it moves through circulation. Then you have metabolism, and the major sites of metabolism are the liver, the kidney, and the intestinal cells. And this is how the body is altering the drug, or what's called biotransformation. And it's accelerated by enzymes, for example, the P450 system in the liver. And in some cases, the parent drug will become an inactive metabolite, meaning it doesn't have physiologic effect. And in some cases, it might become a active metabolite that still has some type of physiologic effect. But for the purposes of trying to gear this medication up for excretion, you might want at the bottom there where it describes becoming more water soluble. You might want a more water soluble product that you could then pee out. This is an example of a partially active metabolite that then becomes an active metabolite. And this is a more active metabolite. So certain medications actually become more active when they are acted on by, for example, the liver. And that would be considered a prodrug when the medication is inactive in its initial form. So that brings us to excretion, which is the removal of the drug from the body. The routes of drug excretion, you have generally the kidneys, the liver and the biliary system, the lungs, as well as the sweat and saliva. This is an example of a nephron and renal tubule with drug moving out into the urine. Biliary excretion, when the drug passes from the liver into the bile ducts, and then is secreted into the GI tract, the small intestine, and out in the feces. And exercise will actually affect pharmacokinetics in some ways. It's not completely understood, but there may be an effect of exercise on the blood flow to the GI tract, as well as maybe effect on the gastric emptying time with strenuous exercise, maybe increasing that, and light exercise decreasing. As you know, when you exercise, the blood moves to the extremities and the muscles and decreases to the gastrointestinal tract. So that can affect oral absorption, whereas with parenteral absorption, increasing blood flow with exercise will typically increase the drug absorption. And things like ice packs that decrease blood flow, causing vasoconstriction, may decrease the drug absorption. We think about movement and massage as increasing drug absorption as well. And then for urinary excretion, the exercise effects on decreasing renal blood flow can decrease renal clearance potentially. Maybe changes in urinary pH that occur during exercise may have some effect, and having decreased urine output may have a faster reabsorption of drugs as the body tries to hold on to more water in a dehydrated state. This brings us to chapter 3, which is some of the pharmacodynamic principles. And some concepts here that we've already talked about, it won't belabor. But the receptor theory, I think, is an important element to talk about of how drugs work. Any macromolecule in the body that a drug is binding to initiate a biological response is considered a receptor. And oftentimes these receptors are targeted by drugs and to try to replicate a physiologic process that is initiated when interacting with that receptor. Here are some examples where you have sort of this lock and key model of drug A being more triangular and acting on the receptor that looks kind of like a V, causing a response. And then you might have an example of neurotransmitter B. When it binds to the more U-shaped target in the middle there, it causes there to be no response. And it's perhaps blocking that receptor, which might have pharmacologic benefit. And similarly, that hormone C affecting on the rightmost receptor there having a particular response, but you wouldn't be able to have drug D interacting with that same receptor because of the significantly different shape in its most sort of basic understanding here. The way that we would label these would be to say that hormone A is a agonist that initiated a response, drug B is a antagonist, or a blocker, and the selectivity is what we refer to when we say that a particular medication, it has a really high affinity for a particular receptor. It's very selective. And with beta receptors in the sympathetic nervous system, you have, for example, beta 1 receptors on the heart and beta 2 receptors that are predominantly in the smooth muscle and the bronchioles, so at least clinically what we often care about the most here. And so when you activate beta 2 selectively, you'll cause more bronchodilation without having as much of the heart rate increase. Or if you try to block beta 1 receptors to lower heart rate, your goal would be to try to have more selectivity for the beta 1 so that you're not also blocking the beta 2 and causing more of a bronchoconstriction. And when the drugs are interacting with the receptors, they can form complexes. And again, that concept is considered affinity. Here is a graph of the percent of maximum response with increased dose of this particular drug. And you'll note that at a certain point, no matter how much more drug you add on the x-axis, you don't get any additional effect on the y-axis. And different medications will have different graphs for these types of relationships. The ED50 is the dose of the drug that is effective in producing 50% of the specified response. Potency is the comparison of the drug dose required to produce a particular effect relative to the dose of another drug. For example, a high potency steroid versus a low potency steroid. You'll need less of a high potency steroid to create the same response. And you could use the term equipotent dose to say that two different drugs will have the same effect at particular doses. The therapeutic index is one of the ways that we measure drug safety, and it looks at the ratio of a lethal dose to the average effective dose. And the larger that you have a window for that, the greater the margin of safety is. Whereas a very narrow or low therapeutic index means that the difference between an effective and a toxic dose is more close together, and that might make you more concerned for safety and adverse effects. This graph demonstrates what happens when you have multiple doses. When you look at the jagged line there, looking at the actual blood level of the drug, you can see that as it sort of dips, each of those black dots is where there is a dose that is taken. So for example, let's say this is Tylenol being taken every 4 hours. The initial concentration goes up fairly rapidly, comes down sort of slowly, and then goes up again. And you'll notice that after the fourth or fifth dose, it's leveling out pretty flat and becoming what we call steady state, meaning that if you continue taking the medication every 4 hours, it's going to be at that level of about 40, and kind of the average will stay in that 40 range. Whereas if you take a larger maintenance dose or shorten the interval between the doses, you'll have a higher blood concentration of that medication when it becomes steady state. And so that initial portion is the few doses at the beginning to get you to the appropriate level would be considered a loading dose, getting you to your desired therapeutic concentration faster, and a maintenance dose, which is the dose administered at the regular dosing intervals. And not all medications require or benefit from a loading dose, but important concept to be aware of. Sometimes medications, when they're administered together, will have an additive effect. There may be synergy between the two medicines having a combination effect that is more beneficial. And sometimes there's an antagonistic effect, meaning that drug B maybe dilutes or hampers the effect of drug A. The placebo effect is an interesting phenomena that when we can't attribute a response to the pharmacological effect of the drug, and sometimes we think that this is related to sort of the mind-body connection, maybe due to release of certain hormones or neurotransmitters as a result of the patient anticipating the effects of using that drug. And so this is why we see sometimes beneficial effects from, for example, the sugar pill in studies that are head-to-head studying new drugs. Tolerance is the term that we use to discuss the diminished response to a drug over time. Folks who drink alcohol very regularly may need to increase the dose of the alcohol that they're drinking in order to get the same effect as they previously obtained. The concept of cross-tolerance is when you have a similar class, a drug from the same class, that you now have tolerance to based on usage of a different drug, but of the same class. And this typically develops slowly over time and is due to the effect of induction of enzymes and changes in the number of receptors predominantly, or the responsiveness at that receptor. The way that drugs affect patients is often going to be within sort of a window, but some folks will be affected a lot more or a lot less by the same medication and dose. And so it's important to know that we sometimes need to customize these treatment processes and think about, is this medication something that the patient is actually going to take? Can they afford it? Do they have the ability to take a 4-time-a-day medication? Is there an alternative that's a once daily that might be more helpful? Is there some education that we can provide to help the patient? Sometimes there's calculations that need to be done to identify the correct dosing based on weight or body surface area. A lot of times this is in children, and so I particularly would encourage you to use calculators. Even medications like Tylenol can become very dangerous for young children when not appropriately age or weight dosed. And then sometimes we'll need to monitor drugs for their plasma concentrations and make sure that they're at a steady state in a therapeutic window. For example, certain anti-seizure medications that we might monitor to make sure is in the right window, and that tells us that the patient is taking it appropriately and that it's in a range thought to be therapeutic and actively preventing seizures in this case. And as folks age, the way that they metabolize and excrete and absorb medications may change, and they may require varying doses of the medication. We might need to think more about how a patient's comorbidities affects the safety of a medication, how it may affect the liver or the kidneys, for example, and how that may affect their long-term health. If they're, for example, kidneys are not filtering blood very well, are they more likely to have a toxic buildup of the medication that we're administering? Thinking about drug-drug interactions or other types of drug interactions like with food or herbal supplements, it is very important to look these things up. Again, very hard to memorize, to have off the top of your head, but if there's any concerns about a patient taking a new herbal supplement, you know that they're taking certain medications, using a reliable online tool to try to identify whether there's any clinically significant drug interactions to be aware of. And then sometimes we may actually use those interactions beneficially for their therapeutic effect, but oftentimes we're worried about it reducing the effectiveness or causing toxicity. In the case of two drugs binding to the same receptor, one drug may displace the other and diminish the response. So in this example here, they talk about an agonist and an antagonist. And you may have an agonist and a partial agonist, for example, with opioids. Patients who use full agonist medications like or drugs like heroin and then start taking a partial agonist like Suboxone, it will have high affinity for the same receptor and push the heroin off of those receptors. It can actually precipitate withdrawal by binding to the same receptors. The enzyme induction or inhibition is some of what we talked about by causing more or less effectiveness. There can be physiologic agonism or antagonism with how drugs interact. It may change the absorption of another drug, as we discussed with calcium and iron, and it can also affect the excretion. Perhaps it changes the pH of the urine and maybe makes it harder to excrete the other drug. Adverse drug reactions are really any undesirable response to a drug, and they can range from minor to life-threatening. Sometimes they can happen after just a dose, sometimes after more continued use, but any time that you have that undesirable response to the drug that may create a safety concern, consider that an adverse drug reaction. It may be a side effect, a known side effect of perhaps the medication caused a headache or fatigue, and that might just mean you need a dose adjustment or a similar medication of same class or a different medication. Allergic reactions, when patients are sensitized to a medicine and then get re-exposed to that, it can create urticaria, rash, but it might also cause anaphylaxis, which is a medical emergency, and want to make sure that you then document any allergies in the patient's chart so that they are not administered that same medication. And also important when you're documenting allergy to document what the allergy was and not just what the allergy was to. In the athletic training setting, these are three important causes of drug allergies in that you may see, particularly penicillin allergies, cephalosporins, which are another type of antibiotic that we'll talk about in the part 2, different non-steroidal anti-inflammatory drugs, and sulfonamides. There can be direct toxic effects to organs like the liver, the kidney, as well as other adverse effects depending on the patient's state. For example, the pregnancy state, where the medication may be teratogenic, for example, to the fetus. There are pregnancy risk categories, as you can see here. This sort of format is not really advocated for anymore, but you will see folks still using this classification. But the idea of it is trying to understand whether that medication has solid evidence or no solid evidence for safety or risk. Pharmacogenetics refers to how genetic changes impact a drug action, and for example, folks who are hyper-metabolizers of medication maybe have variations in their cytochrome P450 system in the liver that increases the rate at which a drug is metabolized, whereas some folks may have lower genetic susceptibility or genetic predisposition to that having a lower functioning cytochrome P450 system, and then that person might actually need less of the drug to still get to the desired effect, depending on whether it's an active or pro-drug. Medication errors are very important because they are unfortunately more common than you'd like to think. So always confirming the right dose, the right patient, the right drug, the right route of administration, the right formulation, and making sure to very clearly communicate this information. Making sure to read carefully, as some medicines have very similar sounds or spelling, and certainly when writing medications, trying to list the doses with the appropriate decimal points to not avoid a logarithmic change in the dose that's administered. As we described, exercise may change some of the parameters of how these medications are acting or being absorbed. They might also be employed as therapy for the same conditions, not that is non-pharmacologic.